name is Aris Wanjiro Gedenji. I'm the Deputy Nurse Services Manager, Tomotomo Hospital. This is Tomotomo Hospital. We are going to have a topic on hypertension in pregnancy, which will be presented by our consultant gynecologist, Dr. Jage. This is in connection because we are having a celebration for Health Week. That will be from 4th of October up to 10th. So we'll have Dr. Jage. Can we welcome Dr. Jage with a clap? Dr. Jage, you are welcome.
Happy to be here, and I'm happy you're all here. Our topic will be quite short, but before that, there's one verse in the Bible I like to read. I hope I'll find it, and it's in 3 John. It's actually 3 John chapter 1, verses 2, thereabout. It says, "Dear friends, I pray that you may enjoy good health and that all may go well with you, even as your soul is getting along well." I like to start with this verse every time I'm having a presentation. So first I want to start by thanking PCA Tomotomo for this opportunity, and most importantly, nawashukuru nyi wote. I feel I'm where I'm supposed to be as a gynecologist in a room full of women. This is good for me. I also want to thank Kalk TV for giving us an opportunity to have this time kuongelea mambo ya afya zetu. And this week is going to be the Health Week, Health Talk. So I thought of one topic that really relates to women. I remember back in creation when Adam and Eve were being ordained. I used to like to use the word ordained. They were told, go and fill the world. Sindio? And what did that mean? Actually, God had a sense of humor. He said, go get pregnant. And he told Adam, go impregnate Eve and get pregnant and get babies, get babies. And so I think pregnancy is divine. Sindio? Because this was actually ordained from the beginning, and the Bible says the beginning and the rest. Unfortunately, something that was purposed to be very divine and very good, things happened along the way. Of course, we fell into sin and we ate of the fruit, and then everything else happened. Kutoka hapo dhambi ikaingia, and vile dhambi iliingia, this is what happened. We started getting diseases, we started dying, we started killing each other and the like. And more so, what we have found is something that was meant to be very okay and very divine, that is pregnancy, started getting its complications. Na tumesisikia sisi wote. Sindio? You get a child, you get pregnant, life starts moving on and all is okay. All of a sudden, you start coming to us with complication and problems and the like. Unfortunately, we have to sort it out, and sometimes things go as we anticipate, other things don't go as we wish for. Now, one condition that is very, very common in pregnancy is all of us. How many of you don't desire to get pregnant? Okay, none. I'm even happy that guy did not put up his hands. But I'm assuming he hoped to impregnate someone someday. So we all, as women, we feel complete when we become pregnant. When we have a life inside us, it's usually so complete. And there are certain things that happen, and the process that happens whereby things start going a little bit unwell. Now, one of the commonest conditions is hypertension, ama blood pressure kupanda. Nani anajua blood pressure, normal blood pressure inafaa kuwa ngapi? Someone? Ile BP ya kawaida normal inafaa kuwa ngapi? Wenye wamekuwa akienda antenatal, umekuja antenatal? Haya, umeambiwa BP ya kawaida ni ngapi? Unajua Sister Kimondo yuko hapa na ndo in charge. So kama hajawaambia inafaa kuwa ngapi? It should be about 140 ile ya juu na 90 ya chini. Okay? That should be about what we call the normal. But sometimes during pregnancy, something go wrong. And hii blood pressure inaanza kufanya nini? Kupanda. Na ikipanda, it's usually not good. Because what happens, the blood pressure will now affect mama and will also affect mtoto. Okay? So it's usually not good. So that's the reason why ile wakati unakuja clinic, every time you come clinic, it's must and it's mandatory, mnaanza kufanywa nini? Kupimwa blood pressure. Kama kuna kitu itachukuliwa every time unakuja for antenatal ni blood pressure, because you want to make sure that your blood pressure is normal. Now, unfortunately, kuna wale wanashika mimba bado wako na hypertension, ama blood pressure yao iko juu. Now, those ones we say they have chronic hypertension. Okay? Lakini kuna wale ambao wanapatwa na hypertension after kushika mimba. And that one we call it hypertension in pregnancy. That is very, very common. Now, the one that is very particular to pregnancy, ukishika mimba, alafu after 20 weeks, ama after 4 months thereabout, ukishikwa na blood pressure after 20 weeks, now that is very concerning. We say this blood pressure imekuja sababu ya mimba, and it has a name. Ili tuelewane vizuri, so kuna hii nimesema chronic hypertension, umekuwa hauna mimba, lakini for some reason ulipata blood pressure. Kama uko na blood pressure, unakuja unatuona, tunakuandikia dawa just to make sure that we maintain isipande wakati wa mimba, isiende kupanda, because kama uko na hypertension before you get pregnant, most likely when you get pregnant itashutu zaidi. So it's important uonekane kabla ya ushike mimba. But after 20 weeks, okay, so that can be before 20 weeks, or if after 6 weeks, which we call after 6 weeks, blood pressure inaendelea after kujifungua, then that is chronic hypertension. Tumeelewana? So hii ya hypertension, ile ya mababa zetu wamezeeka na nini, kidney zimeanza kuleta shida, blood pressure inakuwa, hiyo ni tofauti na ya yule mama mjamzito. Okay? So ya mama mjamzito tumesema inaanzia wiki ngapi? 20 weeks. Okay? And there's a reason why. The reason to that, sio lazima mkumbuke hii, ni kwamba saa ile placenta ya mtoto inajishikilia kwenye nyungu ya mama, or on the uterus, kuna blood vessels zenye zina, unajua mtoto anapata chakula na oxygen kutoka kwa mama. Sawa? Unajua anapataje? So unakuwa kuna damu inaenda kwa nyungu ya mtoto, kuna vessels, alafu ndani mtoto anakuwa na nini? Na placenta inajishikilia. So zile blood vessels za mama na zile zingine za mtoto zinafanya nini? Zinashikana. So there is communication. So mtoto waste inarudi kwa mama, chakula na oxygen inaenda kwa mtoto. So that's how the baby and the mother communicate. So this is what happens. So that you get enough blood pressure kwa mtoto, zile vessels ambazo ziko kwa uterus zinapanuka. They relax and they enlarge. Okay? So that more blood and we said oxygen and nutrients are able to travel to the baby. For some reason which we don't understand, hata sisi madaktari, that process does not happen. So ile kupanuka kwa zile vessels haifanyiki. So they remain narrow. When they remain narrow, the brain is very smart. All our bodies are very smart. Hatuombi ruhusa. Nasema tunataka kupatia mtoto mdamu, lakini mshipa ni kidogo. So inafanya nini? Inaongezea pressure. Okay? Because now it's detected that the baby needs oxygen, needs nutrients, the blood flow is not going on. So then what happens? The mother gets hypertension. Tumeelewana? So the cause of what we call preeclampsia is the pregnancy. And this is very important because nikidiscuss the treatment, mtaelewa kwa nini. Sawa sawa. So we say the cause of preeclampsia, which is hypertension in pregnancy, is purely because of the pregnancy. So without pregnancy, will you get hypertension in pregnancy? No. So sometimes unasema what was meant to be so good ended up becoming problem because of sin. So the baby was supposed to be very divine and to carry the baby. Then you ask yourself, why did you tell us to go fill the world? And then you fill the world. This baby we are carrying are the ones who are giving us hypertension. Because also hypertension will give us different effects to our body. Now, maybe you'll ask the question, then why? What are some of the causes that will, sababu gani ambazo zitafanya tushikwe na hizi hypertension in pregnancy? Hapa nitajuaje? So sometimes we don't know who is going to have preeclampsia or hypertension in pregnancy. Hatujui the process itachukua, hatujui ni wagani watapona. But what we know, or what studies our science has shown us, is number one, kama ni mimba yako ya kwanza, what we call first pregnancy, you are at a risk of getting hypertension in pregnancy. Sawa sawa, hiyo ni ya kwanza. Kama ulikuwa umeshika mimba na mzee mmoja, lakini kwa shida za nyumbani umeondoka umepata mwingine, there is a high risk that unaweza pata hypertension, because mwili yako sometimes it tends to kind of reject the cells. I'm not saying it's always true, but that's also something tunaona. Sawa sawa. Wale ambao wanashika mimba after 40 years kuendelea juu, when they are old, their body has also start kind of aging, and the response to the pregnancy inakuwa affected kidogo. So tunapata pia wale they get affected by hypertension. Kama uko na shida ya kidneys, kama uko na hypertension, there are some who have family history of hypertension. Those one at high risk of getting hypertension in pregnancy. Sawa sawa. So ni vizuri pia unaelewa, nyumbani kwetu kuna mtu alikuwa anashika, especially our mothers, what we call immediate relatives. My mom alikuwa na hypertension. So if, for example, your mom is hypertensive, there's a high chance that you might get hypertension during birth. It doesn't mean you'll get hypertension, but there's the risk factor, what we call the risk factor, that you could be hypertensive. If, again, we say this is your first pregnancy, it's very, very important that you make sure that you're getting the blood pressure tested every time you come to the clinic. And please, uliza sister, blood pressure yangu ni ngapi? Sindio? So when we know ourselves, then we are able to really monitor things when they change. Now, unfortunately, sometimes tunapata, they are not really symptoms. Mwenyewe utajua ya kwamba I have hypertension. Okay? So wale ambao tunapata wako na hypertension in pregnancy, it's usually saa ile wamekuja tunapata blood pressure zao zimefanya nini? Zimepanda. During the routine, what we call the routine checkup. Umekuja blood pressure yako iko 150, unaambiwa iko 150, alafu tunasema hapana, mimi haiko 150, niko sawa, mimi hakuna kitu nasikia. Haya, sasa nakwambia sasa iko 145. Benye utafanya, enda upumzike for 4 hours, urelax, alafu ukuje tena. So if you go and rest for about 4 hours, urudi tena, wachukue blood pressure, wapata iko now 137 over 93, then you have hypertension. Tumeelewana? Lakini ukikuja, the first time umepimwa blood pressure tunapata iko huko juu ya 160 ile ya juu, na hii ya 110 ya chini, that one is purely hypertension. Hata utaambiwa ngojea 4 hours, is diagnosis of hypertension. Tumeelewana? So what I was discussing, how do we make a diagnosis of hypertension? Number one, if your blood pressure is above, ile ya juu iko above 140 but below 160, na ile ya chini iko above 90 but below 110, you be told ngoja kidogo for about 4 hours. So we take two measurements, ya kwanza na ya pili. Ya pili ukirudiwa, alafu tunapata ya kwamba bado blood pressure iko juu, iko bado 139 or 3, ya chini iko 90 something, then you have a diagnosis of hypertension in pregnancy. Okay? Ukipatikana blood pressure imepanda, sister atakwambiaje? Sasa kinyo utafanya, enda kwenye lab, upime mkojo. And that's the reason why when you start your antenatal, najua mnajiulizanga, nimeambiwa nipime blood pressure, nimeambiwa nipime syphilis, nimeambiwa nipime mkojo, hizi zote ni za nini? Okay? Because we know kuna zile changes ambazo hubadilika when you're pregnant. Now, kama blood pressure iko juu, alafu upime mkojo tunaangalia kama kuna chembe ndogo, the protein. We call them proteins in urine. If you have protein in urine, now that is a confirmation that you have preeclampsia. Sawa. Kuna nini? Isemeni vizuri bwana. Kuna nini? So, you have preeclampsia, okay? So preeclampsia therefore ni Blood pressure imepanda na nini ingine? Na protein wapi? Good. Naona sasa tunaelewana. So when you have high blood pressure and then there's protein in urine, that means you have a condition called preeclampsia. And preeclampsia is only and only and only in pregnant women. So for example, if I'm a man and I have hypertension and I have protein in urine, do I have preeclampsia? No. Why? Because I'm not pregnant. Tumeelewana? Leo mtakuwa madaktari kidogo by the time you're leaving here. So we find then, if I'm a man, then daktari atanituma niangaliwe kidney zangu ziko namna gani, maybe zimeanza kufail, things like that. But in pregnancy, we know that is preeclampsia. Okay? So now the question is, if you have preeclampsia, therefore, what do you need to know? So what you need to know is that, number one, we have said that the condition is because of pregnancy and because you're pregnant. And as long as mtoto ako ndani yako, that condition will remain. So what do you think would be the treatment for preeclampsia? The treatment ya preeclampsia, mama. So the treatment for preeclampsia is to what is the cause of preeclampsia? The pregnancy. So the treatment of preeclampsia is getting rid of the pregnancy, but not so soon. Not so soon. So what we need to understand is the treatment, and the true treatment of preeclampsia is getting rid of what we call the products of conception. Product of conception is the baby, the placenta, and the fluid and everything. That is the treatment, okay? Purely treatment. But of course, hautakuja hospitali, tunapata uko na preeclampsia, tunapima, how your liver is and the like. We don't tell you now, okay, fine, mama, you have preeclampsia. Now what we need to do is to terminate the pregnancy. No, we don't tell you that. What we need to do is, can we manage the blood pressures? We lower the blood pressures, and we help you continue with the pregnancy. What we know for sure and for a fact, kama blood pressure ama preeclampsia itakushika very early in pregnancy, is going to be a little bit difficult moving on. Okay? We are not going to terminate the pregnancy. We still try to manage and monitor and see how you are responding, but it's going to be a little bit difficult. Okay? If we catch it a little bit later in pregnancy, then that's usually a good thing because the baby has matured, the baby has grown, which is a good thing. Okay? Now, in terms of preeclampsia, there's different severity. So you can have that one which blood pressure is above 140, below 160 ile ya juu, ama ile ya chini iko above 90 but below 110. That is just preeclampsia. Now, if you have them higher than that, then that is called severe preeclampsia. Now, it's a severe disease. And if you get that about 23, 24 weeks, we know that now if you have high blood pressures, what will happen is possibly it's also going to affect other parts of your body. Because when you have high blood pressure, we know all parts of our body, there's what? There's blood. Okay? And when you have high levels of blood pressure, it's going to affect almost every part of our body. So our kidneys, our eyes, our brain, name them, everything, our lungs. So when we have a woman who has high blood pressures or severe preeclampsia, we'll find that they'll present, if they have that severity of the disease, they'll present with different symptoms. So mama akikuja anasema naumwa na kichwa, that is not a good sign. Mostly they say nasikia kiungulio, naumwa na hapa kiungulio. We know that's usually, if you find your blood pressure ziko juu, we know you'll see your heartburn. Hapana. What that means, your liver imekuwa ime-enlarge kidogo, kuna certain, mshipi hivi inashikilia the liver, and then when it gets stretched, you're going to feel pain that almost feel kama ile ya kiungulia. Ukiweza kusema sioni vizuri, nilikuwa naona vizuri, but all of a sudden, then, So those are usually signs that tells us this is a severe disease. So anytime you're pregnant, or you have your friend who's pregnant, and then they start complaining about these things, niliamka jana and I felt that I was getting this very bad headache. Mostly usually the frontal headache. Then you want to tell, hey, ebu pitia upima blood pressure tuone iko namna gani. Because if the next clinic will be about 6 weeks, most of the time women don't come until there's something really bad. They will only come when we give them a date to return to the clinic, okay? So if they say, okay, fine, for some reason naamka asubuhi sioni vizuri, then you need to tell them, okay, maybe you need to really check and find what's going on. Ukiweza kusikia kiungulio, of course in pregnancy, especially early pregnancy from about 13 to their weeks, a woman will get a bit of kusikia nausea and a bit of heartburn. That's okay. But when you're getting above 20 weeks and thereabout, you're getting this pain around your chest. It's very important that we check your blood pressure and your urine. Sawa sawa. So I was just discussing what a woman might feel. Some kufura mguu, which is usually a common presentation in pregnancy, whereby naona wengine wameanza kujiangalia miguu zao. Don't worry about it. So you'll find that mguu imeanza kufura, usually, especially in the morning. If you have a bit of swelling in the morning, it's not necessarily meaning you have preeclampsia. So msianze kuangalia, oh, kwa nini mguu yako imefura? Uende kuangalia preeclampsia. So we know during pregnancy, the uterus starting to enlarge, the blood vessels that goes to the legs usually go around what we call the pelvis. And when the uterus is getting big, and the whole day you've been standing and walking, we know that the pregnancy is going to compress on these vessels. So if you're compressing on these vessels, especially one that takes blood back to the heart, what will happen is not going to be blood flowing back to the heart, so the legs end up swelling. And then at the end of the day, when you go and you rest in the evening, and in the morning you wake up, poof, everything is okay. And that's still the same reason why we say you need to lie on your side. The reason why you lie on your side is to not compress the blood vessels that take blood to the heart. So you find that your legs will not. But if you're having this swelling of the legs, that could be indicating that maybe your kidneys as well, now they are getting affected by the high blood pressure. So the reason why we never include, and I had to explain the swelling of the legs, it's not as it's not very very strong indicator that this could be preeclampsia. Sawa sawa. Tuko pamoja. So we have talked about the presentation, things that you need to feel for when you're pregnant, when you need to see your doctor, what needs to be done. Lazima pia wewe mwenyewe ujijue. Ukienda hizi clinic tunaendanga unapima tu blood pressure na mbiko juu, unaambia hebu nipimeni mkojo, waelimishe pia wao, si ndio? Sometimes you tend to, you have a condition, you go to these clinics, tunafungua kando ya kiosk na nini, pima blood pressure, unaona iko juu, nakwambia uko na BP. Si ndio tunaambianga? Uko na BP. So waelimishe waambie, daktari, could I be having preeclampsia maybe? Then watashtuka. Okay? So the most important thing is really understanding.
Are you looking for affordable land to begin your investment? Reproductive Society Limited brings you Baraka Gardens. Baraka Gardens prime plots are located in Juja, one of Nairobi's most sought after towns for investments. The plots are located 1 kilometer from the upcoming Great Eastern Bypass and only a few meters from Juja Farm Ardhi Shopping Center. We are offering a 40 by 80 acre plot at 560,000 Kenya shillings for members and 600,000 Kenya shillings for non-members. Book yourself a plot today with a deposit of 200,000 Kenya shillings. The installments are 60,000 Kenya shillings for members and 67,000 Kenya shillings for non-members, payable within 6 months. Baraka Gardens is a ready-to-build investment with electricity and water readily available. Get in touch with us today to become part of the bustling Juja neighborhood. We have other projects in Juja Farm and Kanguda Road. Our offices are located at Muho Avenue, South C, Nairobi. For more information, contact us on 0708 145 222.
Our world needs humble, confident, bold, and integrity-infused leaders.
Live online, Thursday through Friday, October 14th and 15th, 2021. Join thousands of curious, growth-minded, change-driven men and women like you for the premier leadership event of 2021, the Global Leadership Summit. Some of the world-class faculty includes Craig Goshel, Senior Pastor of Life Church, Jami Lima, Richard Montanes, who started off as a janitor and rose to be a top executive. Local faculty include Justice Daniel Musinga, who'll talk about the quest for justice, fairness, and equality. Bishop David Oginde, CEO and founder, the Carter Lead Associate. Daniel Kamau, CEO, Fusion Capital. Archbishop Eliud Wabuhala, Chairperson, Ethics and Anti-Corruption Committee. Among other speakers, guest musician will be Florence Morethi. To register, call 722-490325 or visit www.kenyaleadership.org. Everyone wins when a leader gets better.
Kwenye makala ya kwanza ya jukwaa la moderator.
Tunapojiweka mbele katika mambo yote tunayofanya, huwa tumeenda kinyume na matakwa ya Mwenyezi Mungu. Hasira moja iliyokuwa na Mungu ni kuhusu watu wanaojipenda. Kazi ya Mungu inapaswa kupewa kipaumbele. Kuna uwezekano ya kwamba tukisikiza ushauri wa Mungu kwa njia inayofaa tutakuwa sawa kwake, sababu Mungu ana rehema.
Kuanzia Jumapili hii saa 1:30 jioni na kila Jumapili ya kwanza ya kila mwezi, ungana naye moderator wa kanisa la PCA Mchungaji Thegu Mutahi kwa mahubiri, mafunzo na ufafanuzi wa kiroho kuhusu masuala ibuka nchini hapa KAK TV.
Tafakari njia zako.
Now, the question is, how do we therefore manage hypertension in pregnancy? Unlike someone who's not pregnant with hypertension, in pregnancy, there's a challenge because we consider two lives. We consider you and the baby, okay, or the fetus. And what we also know is the following. Zile dawa ambazo unakunywa ama unatumia, hata chakula, inapita kwa nani? Kwa mtoto. Sindio? So there's able to, of course there are other things that don't azipiti kwa placenta, what we call there's a barrier. Also God is very smart. There are things that are not allowed to cross to the baby, but there are those that actually cross to the baby. And those that cross to the baby, the effect that they give you as a mother, they'll cause the same effect to the baby. The only problem is you take a higher dose because you're big, okay? But then if it's the baby, then they are going to cause a very, much effect because the baby is small. So the drugs that you use, we have very, very limited types of drugs that we use in pregnancy. So if you go somewhere you have been told that uko na hypertension na unapewa dawa, it's very important kuuliza daktari, hizi dawa unanipatia, are they safe in pregnancy? So this is what we call pregnancy medication in pregnancy, or safe medication in pregnancy. There are those which are not safe medication in pregnancy. And that's very important for you to understand. What are some of the drugs? Mnasikianga gani? Ni gani mnasikianga sana? Unaona mnasikia methyl-dopa. There's a drug called methyl-dopa. There's a drug called nifedipine. Those are the medication that we give you. But usiende tu useme hebu nipatie kale kadawa kadogo ka red. Okay? So please don't treat yourself. If you find that you've been, or if you're not sure mahali umeenda umepimiwa umeambiwa iko juu and you're not, unajua kuna mahali tunaendanga unapimwa alafu unaelezewa no, here I'm not very comfortable what is actually being treated. So you need to come to a hospital, you need to see a doctor, if possible see a gynecologist or an obstetrician, then you have a discussion. So number one, when you come to the hospital, what do? We need to be able to tell how the severity of the disease is. Is it just preeclampsia or is it severe preeclampsia? Okay. If it's severe preeclampsia, now we start having a very serious discussion. Now that's one. Number two, we also need to consider mimba yako how many weeks. If it's about 37, oh, that's good. Even if it's preeclampsia, you say, you know what, mama, now blood pressure zako zimeanza kupanda juu, tukiadjust teremsha kidogo, and then we can think about delivering the baby. Because we know after 37 weeks, the baby is grown enough to be able to live outside the uterus. If the baby is below 34 weeks and it's very severe, then we'll say, okay, fine. We have to admit you, we try to control your blood pressure. We have a high dose that we can give you of medication and hopefully you respond. The only thing that we are doing at that time, tunajaribu tu kukupatia a few more days to see if the baby will grow bigger or will mature. Because if we get the baby when they are not mature, especially their lungs, they will not be able to survive outside the uterus. So we have to ascertain those things have been met before we actually make a decision. So there are those that they come, we give them medication, hata sio za za mshipa, tunapatia dawa, and then we find they are responding very okay. And then their blood pressures are controlled. Now for these patients who are on medication, hatuwaoni on the same interval kama mama mwenye hana shida yoyote. So we book them in a clinic which is called high risk antenatal. What does that mean? That means we need to see you quite often. Sawa sawa. And then we need to make sure that either we tell you, enda nyumbani, unapotumia hizi dawa, make sure either ununue BP machine yako, ama utafute mahali utaenda at least 3 times a week. We make sure that the blood pressure is being taken. And we are going to educate you. We'll tell you, ukiona blood pressure imeanza kufika hapa, please come back. So when you come back, 2 things, either we are going to add the dosage or we are going to add another medication. So we start with one medication, mostly hiyo inaitwa methyl dopa. Tukianza na methyl dopa, we see how you're responding. As the pregnancy goes, the effect also might increase. Then you come back, we increase on the dosage of methyl dopa. Tunaanza mara 2 kwa siku, mara 3 kwa siku. We give you up to a certain dosage. If you're still not responding, we add a second drug which is called nifedipine. And when we reach the maximum dose of this medication, and we still find your blood pressures are not being controlled, then we'll have a very, very serious discussion. Because we know that if not well controlled and the blood pressures keep going high, you might have very, very bad complications. And we always value the life of the mother. Sawa sawa. Tumeelewana. So there are those who will come to us and we tell them, you know what, mom, we are very sorry, but we'll have to terminate the pregnancy. They say, no, you're very cruel. And we'll tell them, if these blood pressures are not controlled, you might get a stroke or your kidneys might fail. The worst case scenario, you might find a complication that we might lose your life. So, but before, it's usually very rare we get there. But if now things are really bad, that's what we actually explain to you. And we also know in those very severe situations, also the baby will not grow normally. The baby will grow a little bit slower. We really don't see much abnormality, but what we most likely see is the baby grows a little bit slower, something we call growth restriction. Between the size of the baby when we have an ultrasound scan, sababu scan inatuonesha huyu mtoto kulingana na mifupa yake na how they have developed, they are equally to this gestation age. Okay? Na pia tunaangalia siku zako. So let's say for example you are 34 weeks. Let's say based on your dates, okay? And then scan inatuonesha based on the finding mtoto anaoneshana yuko about maybe 24 or something like that. So you see there's a huge difference. So we'll ask ourselves, does she have any condition that could be predisposing her kufanya mtoto anakuwa pole pole kuliko as compared to the dates? And now we call that growth restriction. And these are babies who don't grow very normally. So there are many things that we look out for. There are mothers who have had hypertension. They have not been coming to the clinic. When they come to the clinic, their symptoms are really bad. Their kidneys have been shutting down, and we end up taking them for dialysis. Okay? So these are conditions that are very, very, very serious. And this is the commonest medical condition that is found in pregnancy. That is 100% purely due to pregnancy. Sawa. So at what point, therefore, do we say, okay, fine, I think now it's safe. We think now it's safe. It usually, if after you've delivered, now things will start changing because the cause of high blood pressure has been gotten rid of. Okay? So once we deliver the placenta, we now know the body starts going back to its normal pre-pregnancy condition. And we find that most women will actually go back to their normal condition. Now, remember what we said. One of the risk factors is if you have had preeclampsia before, the chances of you getting preeclampsia in the next pregnancy is very high. It's about 5 times more than a normal woman who has not had preeclampsia. So if you've had a preeclampsia before, please make sure that you have let us know that, hey, Daktari, during my last pregnancy, I had preeclampsia. My blood pressures went high. Of course, nilibeba mtoto mpaka 40 weeks. I delivered normally and everything was okay. So we get to know about it. And then what we'll tell you, now we really need to start observing you very closely before you get to 20 weeks. Once you get to 20 weeks, now we closely monitor your blood pressure. If we see that your blood pressure have started shooting, then we need to start putting you on medication early. This is what we know for a fact. If we start controlling your blood pressure early enough before zipande, you have better chances that you're going to have a very smooth pregnancy. But when you come to us, when your blood pressures have started hitting 180, oh my friend, it's going to be very, 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 very difficult. Tumelewana. So it's very good for you to really understand what is my condition, what do I need to do, when do I need to be seen. And I've already, of course, explained what are some of the symptoms that I need to watch out for, because these are very important. Delivery, how do we deliver if at all we have to deliver? Now, before we talk about this, delivery is the termination of the pregnancy. So if you come to me, if you come to sister and sister sees you and say, oh, your blood pressures are really bad, go see Dr. Njagi, the gynecologist. So you come to me and I'll have a discussion with you. We'll have a very, very long discussion, especially if we have to terminate your pregnancy. Let's say you are 28 weeks and your blood pressures are 180 and your urine proteins are very high, and we find that part of your organs have started, kind of being affected, your liver is being affected, your kidneys being affected, then I will have to really discuss with you and tell, hey, look here, mom, as much as I really want you to continue with this pregnancy, I feel that it's going to be dangerous for you and your child if mine will be to cancel you. And then I'll make a recommendation. What my recommendation will be, therefore, I would consider we terminate the pregnancy. Now, I don't get to decide. Sawa. You get to decide. I'll give you one story. When I was a postgraduate, a patient came and very high blood pressures. She was from a refugee camp, and we discussed. We told her, we need to terminate your pregnancy. And I have to seek an okay. I don't get to decide. I'll have to seek an okay from maybe Sister Kimondo or someone from the Amedik from a different department. So we have to be three, where I say, I'm recommending, as a consultant, I'm recommending termination of pregnancy because abortion is not allowed in the, it's not allowed in the country for this and this and this and this. And then they'll have to, okay, fine, agree. Oh, fine, agree. Fine. So when we three of us then, we agree that I think termination of the pregnancy, and then you have to give us a go ahead, whereby we are going to terminate your pregnancy. It's very, very difficult situation, not only for you, but only for us if we have to make that. It's very, very difficult decision. And none of us wants to really make a decision whereby you've been longing to, to become pregnant, and then now we have to tell you that you have to terminate the pregnancy. But we have to consider your life before the life of the baby. You're always our priority. Always, always, you mothers are our priority. So if now we say we have to terminate the pregnancy, fine, it's going to depend on different things. Can you deliver normally? Have you had a previous cesarean section? Is there any contraindication ama sababu yote ambayo huwezi ukajifungua sawa? Then we'll take you to theater, open the uterus, and then remove the baby. We'll still maintain your medication, and then we are going to monitor you, make sure the blood pressures are falling off. In terms of your 37 weeks and everything is okay and no indication, ama hakuna sababu ambayo gives us a reason why we should deliver you through cesarean section, then there are medication that we'll give you, and then we are going to initiate labor, and then you are going to deliver. Okay. Never go to a hospital, and please understand me very, very well. Never go to a hospital. Oh, you have hypertension. Oh, your blood pressures are too bad. Please, we need to rush you to the operating theater. Please, no. Don't agree. Okay. The best way to deliver a mother who is above 37 is to vaginal delivery. Don't be whatever we tell you, take it as a gospel truth. There are more complications you can get if you go to theater. I'm not saying don't say no. By the moment we tell you yes, go to theater, it depends. And then ask why. You see, you have the rights as the patient. Why am I going to theater? Why can I not deliver vaginally? If they tell you, oh, you cannot deliver vaginally because you have preeclampsia. I said, no, I met someone called Dr. Njagi, and he said, preeclampsia is not an indication for cesarean section. As a matter of fact, I feel I would do well by delivering normally. But if you labor for a long time, and then maybe they have done a test, which we are able to do here, and we check how your baby is doing, and you find that your baby is a little bit affected, then we might indicate do an indication to have cesarean section. So cesarean section, preeclampsia is not an indication unless there's another indication. Either the baby is not doing well or the mother cannot push. Those are the only two indications to actually deliver it. If you have high preeclampsia, we say this baby should come out within 6 hours. But the most important thing, this is very important thing, is we need to first sukisha nini, BP ikishuka, then we are able to now plan for your delivery. The biggest mistake I've seen people do, you come up with very high blood pressure, and everyone is getting all scared, and they are rushing you to theater. Tumeelewana? So the decision on who to deliver and when to deliver is going to depend on, one, what? Their condition or severity of their preeclampsia, their gestation age, ama mtoto wako na wiki ngapi. Okay? Those are two very important things. And then we'll follow you up even after delivery. And then after delivery, tunaanza kushukisha the blood pressure, pole, dawa, as much as blood pressure zinashuka. And then if your blood pressure continues after 6 weeks of treatment, then that means you have chronic hypertension. And then it's only after that now we'll say, you know what, mama, it's time now, I think you need to see a physician, and we send you to a physician who is going to follow you up. And the physician now will have more option of medication, might change you from one medication to another medication, because at that time there's no risk of using any other medication other than the one that we use in pregnancy. Sawa. I think I am done. So that preeclampsia. So now we are going to take questions. And if you don't ask questions, I'll ask questions. Any questions? Yes.
If the patient comes to you with those high pressures, say above 200 over whatever, 120, and they have the severe features, their kidneys are getting damaged, their liver, we've said we want the baby out in 6 hours, right? But first we have to lower the pressures. How low do we want to go before we plan to deliver? Okay.
Well, your question, I think, has triggered me to answer one more question. Now, since you mentioned very high blood pressure, and remember I had mentioned that sometimes these high blood pressures cause issues in your brain. Now, we say there's preeclampsia, we say there's severe preeclampsia, tumeelewana. There's another condition, before I answer your question, there's another condition called eclampsia. Okay? Eclampsia ni saa ile mgonjwa anapata fits ama conversions. Now, if you have preeclampsia with conversion, we call that eclampsia. So, and now that is the very severe part of the condition. Again, the reason I had not discussed it, I'll answer it, is because really that now comes to our management. Now, when you have very high blood pressure, two things, we have to lower them. And once we lower them, we just don't lower them poof, because then, your body is not, so we have to gently lower them. Now, what we do, we give you medication, Yamshipa, IV medication. So we have to, mostly what we use is a medication that is called hydralazine. Now, our interest is on the ile ya chini. Ile, BP inakuanga ya juu na ya chini. So the ile ya chini, we have to bring it down to about 110 or lower. That's when now we feel that this patient is a bit stable to take any intervention. So before we initiate any intervention, the first and the acute management preeclampsia or eclampsia is number one, to control the blood pressure. If this patient therefore has eclampsia, we also have to control the conversions. And there's a medication we also give for conversion. We call it magnesium sulfate. So these are medications that we might give. If you have very high blood pressure, bado huja convulse, there's a medication we might inject you to prevent you now getting to eclampsia or what we call or what we find patient convulsing. So that is our duty now, to first bring the blood pressures low. And this will take about an hour. There are patients who are not going to respond, and now those are the very difficult patients. I hope we don't get that, we've not gotten that. But there are those patients who are not going to respond to this medication, and their blood pressures are going to remain very high. Now, what we know, these are patients who might be very now difficult even after treatment. And we have to be ready for this patient. These are patients which we think that the kidneys might have effects, and these are patients, even after delivery, they might need a little bit of intensive care, maybe taking them to HDU or sometimes even in ICU. But the first management is to lower the blood pressures. Now, sometimes you go to a place whereby they are bringing your blood pressures below 90. Now that's not good, because your body has already adapted to high blood pressures. Okay? And there are certain part of your organs which are now responding to high blood pressures. And the moment you just bring it poof down, what is going to happen is that these organs are not going to now get good supply of blood, because the pressures has been very low. So when we are lowering the blood pressure, we have to be very careful. We have to bring it very slowly and very gently. Once we get it where we want it to be, then we have to maintain it at that point. Did that answer the question? Less than 110, the diastolic or the low, the diastolic. We really don't mind much about the systolic. Yes. Any other question? A question from the patient. Yes.
So in terms of using magnesium sulfate, especially with management of eclampsia, we have cases now a patient is allergic to sulfur, right?
Yes.
So like a role of any other medication, because now like with diazepam, there's always an issue about now the bonding time with the mother,
Yes.
especially after delivery.
Yes.
So like, is there any other?
Apparently, there has not been. We've not found any literature of complication from using magnesium sulfate. It has been thought to be a very safe drug. The reason why hizi dawa zingine za the anticonvulsant medication like diazepam is their effect is very, very extensive. And very small dose, gives you it's a very wide range of effect to the patient. So you find the patient might be completely knocked out. I mean, by that you really put to sleep. It's really sedates you kabisa, and we really don't want this patient completely sedated. But there's role of these drugs. There's role of these drugs if you find that you've given magnesium sulfate and the patient are still getting conversion. You've given your maximum dose. And we have a certain protocol on how we give magnesium sulfate. You have given your maximum dose. You've given your the patient get recurrent of a fit. You give your additional drug. Then there's role of diazepam and the like. Unfortunately, they are not the first line medication that we use, and we've not found any even patient who come and say, "Oh, I'm allergic to sulfur." We've not seen any reaction with magnesium. So it's been found to be a very safe drug, but it's not an antihypertensive. We go wrong sometimes. It has no role in. I mean, it has effects, but has no role in antihypertensive. So it's a drug that will, kind of. The other thing, and maybe this to us more to the patient, is the question that is asked. You want this patient to go into labor, they start laboring, and then you unapatia magnesium sulfate now relax. Ita relax uterus? No. The mechanism of action of uterine contraction is different from the response from magnesium sulfate. And what we find is, once labor ya mama imeanza, you can never stop it. It never stops. It doesn't matter. You can prevent it from happening, especially those who wanaanza kupatwa na labor a little bit early. We know nifedipine works, but once it has started, you don't stop it. All right, question from the patient. Any question? No question? All right. Fine. If there's no question, thank you so much. We want to thank you for joining us and being part of this talk. How many of you thought it was helpful? Good. At least now we know what is preeclampsia, right? So again, as we say, ours to you is to wish you good health and to wish you happiness. I feel that pregnancy should be a very, very enjoyable experience, and more importantly is for us to promise and to vow to you that we will take care of you here in PCA Tumutumu Hospital in case of any issues, any concern. If you're attending our clinics here, please see Sister Kimondo, and she'll be able to answer your questions. If you feel that there's something that was not well addressed, always ask, can I see Sister Kimondo? She'll be able to answer questions, and whatever we need to discuss, she'll always reach out to me. She'll tell me things that we need to help you to make sure that your experience here is a great experience, and you enjoy your journey in pregnancy. Thank you so much, and we'll have Sister Alice finish for us. And from me to you is to say thank you very much.
Okay, thank you so much, Dr. Njage. We are very grateful. Now we have information. Information is power. We here at Tumutumu Hospital, we like to give our clients information because we are esteemed customers. We are very grateful. Thank you so much for the time you have taken. And I'm sure in the future, Dr. Njage, you give more topics on other areas, yes, so that our patient can have information and can be able to take care of their own health. We usually say health for you is the most precious asset. Otherwise, God bless you so much. Thank you, our viewers. God bless you so much. We at Tumutumu Hospital welcome everybody and everyone because we are part of the bigger family from Kenya. Thank you so much.